about bone tumors. I'm not going to talk extensively about bone tumors. I'm going to try and limit it, basically a focus for my experience from the FRCS, try and allow you to hone in your answers so that you don't get too upset or obsessed, because it is a vast subject. Okay? So the key thing is to remember to relax. Bone tumors sound scary, but the reality is the person across the other side won't know as much as you. They'll probably know less than you, because your knowledge should be fresher and more up to date than theirs. They're going to be heavily reliant on the answer script they get there in front of them. So the key thing is not to over elaborate. Try and keep it simple. So the old acronym: keep it simple, stupid kiss. Okay. Now, this is a demonstration when you actually look at the FRC syllabus for musculoskeletal oncology. It consists of 3 lines. So the presentation of radiological features, pathological features, and treatment and outcome for common benign and malignant tumors. You just need to know that generally. That's not, whilst then the principles of management of patients with metastatic bone disease in terms of investigation, prophylactic, definitive, and fixation for pathological fractures and oncological management, you need to know a bit more specifically and broadly. You also need to know presenting features and management and outcome for soft tissue swellings, including sarcomas, a little bit more detail. But they're not wanting you to have extensive knowledge, because there are very few people who will. And the reality is, if you have that knowledge, and you're going along that route, you're one of the few. Okay? Now, I'm hoping that by keeping it simple, you'll be safe and you'll do a lovely save like this when this question arises. Okay? Now, the most important thing is to have a good systemic approach to when you see a common question like this. So they might say, tell me about this image. It's a 13-year-old boy, back pain, relief of non-steroidal anti-inflammatories, and then they might show you this. This was one of the questions I had in my exam. So, no, it's a spinal problem. You can see that little nidus there. Oh, or I'll go back, apologies. You see that little nidus there? Oh, he says. That's consistent with an osteoid osteoma, okay? No real, that is hopefully your introductory question, but they're going to ask you a bit more of details. Okay, or if you're unlucky, you might get something a bit like this. So hands up who thinks this is a bone tumor. Don't worry, I thought I did, but actually it's a common mistake, because this is actually osteomyelitis. Okay? In the bad old days, you might get a question. He says, I'm not trying to draw. Like this, all right? You can see that one. That's not a pleasant one, but thankfully we don't have any frozen section slides in there. Generally, you want to know about the zone of transitions when you look at the X-ray. Have a rough idea of the age of the patient, look for any periosteal reaction, any cortical destruction, and think about the location, in whether it is in the epiphysis, metaphysis, or diaphysis, and also the location within that area, whether it is eccentric, centrally, or just on the edge. Can you also work out whether the matrix, in terms of the bone matrix, whether it's primitive, sclerotic, or a ground glass appearance? And again, is it just one lesion, or is there multiple lesions? That can hopefully help you answer a question like this. Because the reality is, you get most of your answers from the X-ray. So the morphology of the bone lesion on a plain radiograph will definitely tell you whether it's well-defined, osteolytic, or ill-defined, or sclerotic. It can also generally work out the age of the patient, so you can tell this is a skeletally mature person. And it is important, as I said, to stress that actually the radiograph will tell you a lot more. CTs and MRIs are only really important in very selected cases. Okay? And most bone tumors are osteolytic in nature. So the most reliable indicator in determining whether these lesions are benign is or malignant is the zone of transition. So can you decide whether it's a lytic feature, or ill-defined lytic, well-defined, or sclerotic? And then roughly their age. If they're less than 30, and their location, whether it's long bone, axial, arch of the spine, or solitary and multiple. These are the sort of buzzwords you need to be talking about when you're discussing this in the in the Viva. And hopefully you can have a rough idea. So this is just a nice schematic which you've seen lots of times on the internet. You can roughly work out from the position of whether it's in a central position, or such as Ewing's sarcoma, or whether it is on the edge of the metaphysis and epiphysis, like an osteosarcoma, or it could be an aneurysmal bone cyst. So you can roughly work out from the position and whether it's young or old, roughly what type of tumor it might be. Okay. So, and here's another sort of a schematic of how you can further define whether there are. It's very easy to go into this in a lot more, to talk about this and get lost and go down the garden path. But as I say, if you could describe the X-ray in terms of whether, based on the patient's age, the location, whether it is a solitary lesion, multiple lesion, and what you can tell from the matrix, and whether if there's a zone of transition, whether it is narrow or there's a wide zone of transition. And if you can see a periosteal reaction, or if there's any soft tissue involvement. The reality is that you've answered most of you've got yourself onto a safe basis, and the examiner's relaxed. And hopefully you can then start scoring more points when they start asking you about, level one in terms of position of where it could be. Apologize for the busy slide. But most of the points you're going to score is when you talk about the principles of management. Okay? So the key thing is you need to show them you're safe. This is not something we do on a regular basis. There's the NICE sarcoma guidelines from 2015, which you can look at in terms of the British Sarcoma Group. And all hospitals, if you're doing the English, the FRCS in the UK, all hospitals will have a pathway to a sarcoma MDT. They might ask you a subsequent question, what is a sarcoma MDT made of? It typically should include, not exclusive to this list, a specialist sarcoma surgeon who performs sarcomas on a regular basis as part of the multidisciplinary team. There'll be an oncologist, radiologist, oncology nurse, and pathologist. It's worthwhile having a rough idea where your local center is. You're not going to finish it there, but you are going to talk about, you understand the principles in terms of treatment. Okay? So when you're thinking of that, you're also thinking in terms of the workup. So you're the consultant there in the consultation room, you're seeing this patient, you're worried about making sure, do they have atypical pain? Because you do not want to upset your colleagues at the British Sarcoma Group. Do they have neurovascular symptoms? Those are key things they want to know. And you're examining them, you're going to pinpoint any neurovascular issues. You're going to have a clear description of the mass, any lymph nodes, or are there any other systems because you can never rule out a metastatic disease in a bone tumor. Okay? And part of your workup, as we've said, we're going to do a few blood tests. So you're going to do your LDH and alkaline phosphatase because they're very good prognostic indicators in bone tumors. If it's an older patient, you're going to arrange a myeloma screen. You may also do a urine analysis for some of the weird and wonderful ones. Imaging, again, key is plain radiograph of the bone, a skeletal survey, possibly if you're worried about myeloma. A bone scan, they're slightly going out of fashion because they take too long. MRI and a staging CT if requested by your local sarcoma unit. Okay. Now, the important thing is the biopsy. So this is where they want to see that you've actually understood that there are some guidelines out there and you understand them. There are different types of biopsies. There's excisional, which is what we do on a regular basis when we're taking out a ganglion or a lipoma. However, they might ask why we not do this. Well, it recurrence with incomplete margins. We don't do percutaneous ones in the UK very much, unless you're really got a very good relationship with the MDU. And true cut biopsies are less common again here. Incisional biopsy is the gold standard, and that's what they want you to talk about. Okay. Typically, planning. So it's performed by the surgeon, hopefully doing the definitive procedure, or at least involved in that. You want to have a pathologist involved because they're going to be there, maybe by your in the room next door, to take the section and to tell you what type of tumor it is and what you need to do. You need to leave an excisable scar, so avoiding transverse incisions. The approach should not contaminate the muscle compartment, extra muscle compartment. Sorry, I'm just reading that, further muscle compartments. You want meticulous hemostasis, i.e. if you're using a tourniquet, remember to at least before you close and try and occlude as many arteries as possible. And any drain should go out through the wound. Oops, sorry. So when we're sampling the specimen, they also want you to say that you're going for a soft rather than bone, peripheral rather than necrotic, because you're not, the pathologist is not going to give you much information from the necrotic tissue. And the gold standard again is a frozen section. And you will always send samples for microbiology because invariably you can always get an infection that copies it. Okay, and typical histology samples as well. Now, I'm not going to go in detail with the Enkin staging because that's well covered in most textbooks. It's typically post-resection, but it's a good estimate possible preoperatively. Key things are, is it malignant, anatomic, metastases? Those are the key sort of stresses as part of the Enkin. So in terms of anatomic, what compartment is it? Is it intracompartmental, so within bone or fascial compartment? Extra, has it breached the bone or fascial compartment? And that you can help yourself by doing an MRI scan in this situation, because that's very good for anatomy. So the next question they might be asking, so you've got your staging there, you've done your incisional biopsy, you know what type of tumor it is. So is it limb salvage or amputation? Most centers feel that from current guidelines that virtually everything is salvageable, but there are some indications for doing an amputation. The main ones being there's a neurovascular infiltration, which means you're going to have to do extensive radical debridement, which might mean the leg's not or the limb's not salvageable. Again, extensive muscle invasion, so it may involve multiple muscle compartments. There may be a pathological fracture with widespread dissemination. And again, also you have to think as well, because we are caring doctors, so we have to ask what the patient wants as well. And again, they may be asking, so you've decided what you've got, what level of resection you're going to talk about. So they may start going down, you may want to talk about intralesional, so going through the tumor itself. This again is not rarely done nowadays because there's typically 100% recurrence. The one time we might do it is if we're trying to reduce the size of the tumor for pain relief, so in palliation. Marginal, so again, this is another option where we're going through what we call the pseudocapsule. This is the reactive zone with inflammatory cells and tumor satellite cells. This is a situation where you want a good working relationship with your pathologist to tell you that you're still within the margins. However, there's a 50% recurrence. So again, it's not done very commonly, and you often have to do adjuvant therapy with this. So classically, we will either do a wide margin of resection, which is the most common one used in this country. It's intracompartmental, so really en bloc, you're taking the whole compartment out with a cuff of normal tissue typically. It does have a low recurrence of less than 10%, but there still is a recurrence. Again, in this situation, you want to have you need your pathologist available to demonstrate that you have got that healthy cuff of tissue around your compartmental resection. And then the last one is obviously a radical extracompartmental dissection, resection, such as an amputation, for example. That is the most radical we could talk about. And the other thing they might ask you is with regards to other therapies. So we're surgeons, we don't know much about this, so we're not going to expect you to go into too much detail, but understand sort of the principles. When we talk about neoadjuvant therapy, this typically means preoperative, and this is to help usually reduce the size of the tumor and you can help restage and plan your surgery around it. And classically, the level of tumor necrosis, you want to get it to up to nearly 90% to improve your prognosis. And then you typically have to wait a little while before you can start operating. How they might ask you, how does it work? So it is typically programmed cell death, apoptosis, so a bit of basic science there. We always have basic science in this, they love it. So your classic, the main three agents are your alkylating agents for direct damage to DNA, your pyrimidamines, depleting the cellular building blocks, and obviously the new biologics. I'm not an expert on this. You'd ask your oncologist, which is why you have an MDT. There is the classic ones, the most sensitive are the osteosarcomas and Ewings. There is minimal benefit in soft tissue sarcomas apart from rhabdomyosarcomas and soft tissue Ewings. Radiotherapy is still being used quite a lot, and it's a generation, again, in terms of the basic science, it's a generation of free radicals which create direct DNA damage. The main radiosensitive tumors are your Ewings, your lymphomas, and your metastatic ones. So if they've got a primary cause, such as breast cancer, you can direct the radiotherapy there. And it is typically good as an adjunct therapy. So if you have an incomplete margin, or you're treating metastatic pain. However, it does come with complications. So you have a high risk of post-irradiation sarcoma, risk of stress fracture, burns at the site of radiotherapy, wound problems. Yes, I have seen this when I've doing spines where we've had radiotherapy on wounds, and it breaks down and you end up with horrible, nasty infections. They may also start talking about reconstruction options. So you probably don't, so this is one of the reconstruction options. So the most favorite one at the moment is endoprosthesis, which we seem to be doing a lot. So it's generally involving a joint. It has to, because of your radical dissection of the soft tissues, it typically needs to be quite fairly constrained. And in this case, as you can see for this picture, you can see these sort of this serrated edges. That's a sign of a growing prosthesis, which can be controlled with magnets, because a number of the people involved are going to be pediatrics, so still growing. We may also do autografts. So typically we use a fibula. And again, this can also act as a strut graft to augment other procedures, okay, of reconstruction methods. Allograft, again, less used now. It typically, mainly because you're using a massive section of dead bone, so it is slow. It's slow to incorporate or has no incorporation, and there's a high risk of infection. Now, soft tissue tumors, they're also quite important with regards to this. You may be presented with a picture like this as part on your Viva table. So the key thing is all malignant soft tissues tend to be sarcomas. They're of mesenchymal tissue origin. They're usually classified by the tissue of origin, and there's over 50 subtypes. So I'm not going to go through all of those. I just want to go through the key principles. Thankfully, they're very uncommon. Of 7.9 million in this country. They have a centripetal growth pattern. And important, you approach this as with a bone tumor, an MDT approach. It's very much the same group of people involved as with your bone tumor. The key thing is sort of the clinical presentation, which if you read the NICE guidelines is key. They talk about increasing in size. So any lump, any mass that you, soft tissue mass that you see that's increasing in size, more than 5 centimeters and is painful, you should have a high indication of suspicion that this is a malignant soft tissue sarcoma. Okay? And that's from the 2015 NICE guidelines. They've recommended urgent ultrasound scan, not an MRI scan, but an urgent ultrasound scan, and you should be going along the 2-week cancer pathway. These are key buzzwords that you need to be saying in your Viva. Typically, you're going to be the consultant that's received this patient, so hopefully you understand this. And here's an algorithm from the NICE guidelines of what to do. Okay, you can mention this as well, a key for getting more points. Again, you're going to talk about biopsying it. That's what they want to talk about. So the principles are very similar to bone tumor. There's some controversy as to with regards to tourniquet. I know some surgeons don't use a tourniquet. However, if you do use a tourniquet, it's typically without exsanguination. Again, key as with bone tumors, meticulous hemostasis. You're going to take good care of the drain. They love this, either through or directly in line with the wound. You want to be excising the biopsy tract, and typically you're going to have quite a radical dissection. So you may need to think of having a free flap reconstruction. So part of the MDT may involve having a plastic surgery. And again, as with ever, it's deformed by a tumor unit. It's not something we do on a regular basis. And if you are doing it, the principles is, again, a wide excision. And again, you're going to have the same conversation with regards to salvage or amputate as with bone tumors. As I said, adjuvant therapy, again, as I said earlier, chemo has a very limited role in soft tissues. Radiotherapy is very useful, so external beam or brachytherapy. There is no real difference whether you do preoperative or postoperative bone therapy in terms of overall survival. Preoperative, there are some benefits. It seems to develop a thick fibrous capsule around the lesion, which makes it easier to excise. So some units use that. You can use a smaller dose, and less of a risk of wound problems. The only thing is you have to wait 3 weeks before you go in to make sure that you can help the wound doesn't break down. Postoperatively, you do have less wound problems, but there still is that risk of infection, particularly if you don't go in too soon. Okay. Now, they may ask about prognosis with this. So there are well-defined nomograms which are on the NICE guidelines, and there are calculators that you can use, for example, such as this Memorial Sloan Kettering Cancer Center in New York. And the main nomograms are the grade of the tumor, the size of the tumor, how deep that tumor is, what type of tissue it is, whether it's a synovial sarcoma, and the patient age. Again, in this situation, it's good to be young. So does anyone have any questions they'd like to ask?
Does this Viva session, would this qualify for a hot seat session, or is this?
Yes, I think it qualifies for hot seats.
Okay, so we'll stop the recording. We had 37 participants. It's very good for the height of summer with the heat wave and the football. I appreciate all skipping the football to come and to see this much more important event that we've provided for you. We'll stop recording here today, and we'll continue the hot seat Viva sessions. Could you please raise your hand?